Okay, good morning. Thank you for coming today. First, I'm going to talk about a trial for allogeneic transplantation patients with persisting or relapsed disease after transplant. You can see it's entitled Allo T cells expressing an anti-CD19 chimeric antigen receptor cause remissions of B-cell malignancies that progress after allogeneic hematopoietic stem cell transplantation without causing graft-versus-host disease. First, some background. Relapse of malignancy is a leading cause of death in patients undergoing allogeneic stem cell transplantation. B-cell malignancies persisting despite allogeneic stem cell transplantation are often treated with unmanipulated donor lymphocyte infusions. These infusions of unmanipulated donor lymphocytes have very inconsistent efficacy and are associated with significant morbidity and mortality from graft-versus-host disease. We aim to improve the treatment of B-cell malignancies that progress after allogeneic transplantation by infusing allogeneic T cells that were genetically modified to express an anti-CD19 chimeric antigen receptor. So, in short, we're trying to genetically enhance the donor's own lymphocytes to make the infusion of lymphocytes more effective. First of all, what is a chimeric antigen receptor? It is a fusion protein that contains an antigen recognition domain, usually derived from a monoclonal antibody, that's fused to co-stimulatory domains and T-cell activation molecules. The CAR gene is put into the T cells via a vector, usually a viral vector. In the case of the research I'll present today, it is a gamma retroviral vector. The CAR is then expressed on the surface of T cells, and the T cells can recognize the targeted antigen on the tumor cells. Patients with any B-cell malignancy were eligible for this protocol. Patients had to have at least one standard DLI, except for one exception. We would accept acute lymphoid leukemia patients who did not have a prior DLI, because prior DLIs are very ineffective for acute lymphoblastic leukemia. Patients must have had minimal or no graft-versus-host disease and not be receiving any systemic immunosuppressive drugs at the time of protocol enrollment. One very important point about this study, in very distinct contrast to almost all other CAR studies, is that we did not give the patients any chemotherapy. So the results you see will be due to the cells that we infused. There were no other treatments administered at all. So it's a very non-confounded and clean experiment. The CAR transduced T cells were derived from the original transplant donor. So as I mentioned, these are patients that had allotransplants, either matched unrelated or sibling transplants. So we went back to the original donor and asked them for another donation of lymphocytes to produce these cells. The production of the allogeneic anti-CD19 CAR T cells took only 8 days for each patient. This was a phase 1 trial, which was a dose escalation, and the highest dose level reached was 10 to the 7 total cells per kilogram. We treated 20 total patients. We treated 5 patients with acute lymphoid leukemia. 4 of 5 obtained minimal residual disease negative complete remission. That means there was no leukemia detectable by the most sensitive methods, including PCR in one case and multicolor flow cytometry for all the patients that obtained complete remissions. One of these complete remission patients has an ongoing complete remission at 18 months. 2 later relapsed, and 1 went on to a second allogeneic transplant and continues in complete remission. We treated 5 patients with chronic lymphocytic leukemia. 1 obtained a complete remission, 1 a partial remission, 1 stable disease, 2 progressive diseases. Both the complete remission and partial remission patients have ongoing responses at 36 months and 18 months respectively. The partial remission patient has a very small amount of one lymph node that's less than 2 centimeters in her pelvis, which is possibly scar tissue, but officially partial remission by the international staging criteria. We treated 5 patients with mantle cell lymphoma and obtained 1 complete remission and 1 partial remission. And with diffuse large B-cell lymphoma, again, 5 patients treated, 3 stable diseases, 1 CR, 1 progression. The stable disease is ongoing. The patient with complete remission is actually still in complete remission, but she's not evaluable anymore because she received other therapies for her chronic graft-versus-host disease, which could confound results. This is a slide of the patient with diffuse large B-cell lymphoma who obtained a complete remission on the study. This patient, you can see the large lymphoma masses in her head, one in the back of her head, one in her eye socket. 15 days after infusion, we repeated an MRI of her head, and it shows that the tumor masses were completely gone. Amazingly, the tumor masses completely disappeared within 5 days of the CAR T-cell infusion. And this patient, as I mentioned, she had some chronic graft-versus-host disease at the time before we gave the CAR T-cells. This chronic graft-versus-host disease continued to steadily worsen before and after the CAR T-cells, and she went on to get other therapies for her graft-versus-host disease, but continues in complete remission now about 13 months after the infusion. In summary, we've treated many patients, 20 patients with very advanced malignancies. Please keep in mind that these patients who failed all standard therapies went on to allogeneic transplant, which is considered the last chance therapy for these patients, and continued to have progressive malignancy after that. So it's a very, very high-risk patient population. I didn't show today some of the actual slides of the ALL patients, but we had very good responses with ALL, as I mentioned. But many of these ALL patients with high tumor burdens did have severe cytokine release syndrome with fever, tachycardia, and hypotension, among other toxicities that I'll discuss later today, actually at 12:30 today, in much more detail. Neurological toxicity was rare and mild. Only one patient had mild aphasia. This is in contrast to some other CAR studies where neurological toxicity is much more prominent. When chemotherapy is not given, a higher dose of CAR T-cells can be given with acceptable levels of toxicity. No acute graft-versus-host disease occurred after the allogeneic CAR T-cell infusions. Only one patient had continued worsening of pre-existing chronic graft-versus-host disease, which I already mentioned. One patient developed very mild chronic eye graft-versus-host disease more than a year after CAR T-cell infusion, which was probably not related to the CAR T-cells because she had no detectable CAR T-cells in her blood at that time. Thanks.